Hello, and welcome everyone to our seventh topic in NCUI's Project First Line training series for our frontline workers, COVID-19 and infection control. Today's topic is good ventilation and air handling as a part of infection control. We are very pleased that you could join us today. It is our hope that this forum provides an opportunity for you to gain knowledge and foster best practices as it relates to infection control. During each session, we will hear from experts as well as offer opportunities for you to ask questions regarding the topics covered. My name is Tiffany Stark, and I am NCUI's Project First Line Public Health Program Associate, and I will be your host for today. If you have any IT difficulty during today's call, please chat directly to Noelle under Comms and Events in the direct chat, and she can assist you. Finally, if you could, please enter your name, UIO, or external organization, and any tribal affiliations into the chat box so that we can get to know each other and also count your attendance. Before we begin, please note that this session will be recorded for educational and quality improvement purposes. NCUI will be utilizing the recording to continue to share and educate frontline healthcare workers throughout this pandemic. Thank you. Our agenda features a brief recap of NCUI as an organization, Project First Line, as well as our Project First Line team. We will then move into our training on good ventilation and air handling as a part of infection control, with which we are excited to welcome today's trainers, Rochelle Moore from the Urban Indian Center of Salt Lake and Karen Kwok, our NCUI SME. Next, we have our fellow Kaylee Edwards, who will be providing a cultural connection discussion, followed by a short commentary delivered by Dr. Abigail Carlson, from the CDC. We will then be divided into groups for 3 breakout rooms to discuss the posed questions further. Finally, we will wrap up as a group to share our thoughts as well as ask questions as time permits. And I would also like to remind everyone that as we go through the training, you will see information sourced on each slide, and we'll be sharing all resources in a follow-up email with a recording of this presentation and the slide deck as well. To begin, we have a background on NCUI. We are a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaskan Natives in the urban areas. NCUI is the only national representative of the 41 Title V UIOs under the IHS and the IHCIA. NCUI strives to improve the health of over 70% of the AIAN population that lives in urban areas supported by quality, accessible healthcare centers. We would also like to thank the Centers for Disease Control and Prevention for their continued support. Project First Line is a national collaborative led by CDC to provide infection control training and education to frontline healthcare workers and public health personnel. NCUI is proud to partner with Project First Line. The contents of this program do not necessarily represent the policies of the HHC accreditation body, OSHA, CDC, or HHS, and should not be considered an endorsement by the federal government. And now we would like to reintroduce our Project First Line staff here at NCUI. So first we have Dr. Kimberly Fowler, Vice President of the Technical Assistance and Research Center, Zipporah Fuller, Director of Technical Assistance, Evelina Maho, Public Health Program Manager, Diana Pejuan, Senior Project Manager, Melissa Watson, Public Health Project Assistant, Noelle Zulke, Communications Coordinator, Alexander Zamo, Statistician, and Karen Kwok, the SME. For today, we have Rochelle Moore from the Urban Indian Center of Salt Lake, and then we also have Karen Kwok, our NCUI SME, as our trainers. We would also like to welcome Dr. Abigail Carlson from the CDC. And next, we want to recap what Project First Line is. Project First Line is CDC's national training collaborative for healthcare workers, focusing on infection prevention and control. Every frontline healthcare worker deserves to understand infection control principles and protocols so they can feel confident to protect not only themselves and their families, but their patients, facilities, and communities. Project First Line is designed to help frontline healthcare workers to gain that confidence and knowledge through these training collaboratives. And lastly, we would like to provide you with our post-evaluation survey link. We will be providing the link in the chat now as well at the end of the session. Please complete our survey to let us know how we can serve you better. Your evaluation of the training content and delivery will enable us to meet your training needs and improve the quality of our program. And with that, I would like to hand over the training to Rochelle Moore.
Thank you. So our objectives will be to review interventions for improving ventilation and air handling, implement requirements for proper ventilation and air handling, encourage engagement around proper ventilation and air handling within a clinical setting as part of infection control, and demonstrate an understanding of the importance of ventilation and air handling in a clinical setting during the COVID-19 pandemic. Next slide, please. So good ventilation and air handling as part of infection control. Next slide, please. So the main way that SARS-CoV-2, the virus that causes the disease of COVID-19, travels between people is through respiratory droplets. A respiratory droplet is the water in your breath. These droplets can be inhaled by others or land on your eyes and infect others. So patient care in the exam room implies there is patient contact with risk of contact and droplet spread because the clinician and healthcare team members are within 6 feet of the patient, below the recommended 6 feet of social distancing. At this proximity, this patient care interaction is very high risk with collecting specimens and involving exposure to air particles and droplet contact. Respirator, eye protection, face shield, gown, and gloves are recommended. Per the CDC, in addition to ventilation efforts to improve social distancing, wearing face masks and hand hygiene should also be included. Indoor spaces are more risky than outdoor spaces, where it might be harder to keep people apart and less ventilation. Next slide, please. So, environmental domain with COVID spread. What is ventilation? With the movement of air in and out of spaces, we can then consider why controlling spread of germs is important. We will also explore how to control germs from spreading by using ventilation interventions in the following slides. So next slide, please. So environmental domain with COVID spread. What is ventilation? So ventilation replaces the air in the room by pulling air out and or pushing new air in. Good ventilation can help remove things that we don't want to breathe in, like small virus particles from the air or the space we're in. And it's also really important to have good air movement and air quality in healthcare, especially to help reduce the risk of spreading germs, including COVID-19. Respiratory infections can be spread by respiratory droplets released by someone who is infected. The fewer virus particles in the air, the less likely someone will be to breathe it in enough to get the virus. Outside, respiratory droplets get carried away quickly and disperse. Also, the viruses and bacteria in them can be destroyed by things like sunlight and drying, so they can't make someone sick. If a room does not have a ventilation system that moves the air, tools like high efficiency particle air or HEPA filters can be used to clean the air by filtering it instead of removing it. Next slide, please. Infection control program, environmental domain, the importance of ventilation. Enclosed rooms imply there is inadequate air circulation in the room. The concentration of virus particles in the indoor air has increased likelihood of lung inhalation or contact and entry into the tear duct. Thus, entry into exam rooms alone is high risk. Next slide, please. Infection control program, environmental domain, how does ventilation help? Now, for the answer to how ventilation intervention stops the spread of germs. So in the outdoors, the air disperses the germs, dries out the germs, and sunlight kills the germs. With the indoors, old air with the germs can linger whereby HEPA or HEPA filters alone are inadequate and too slow in removing all the germs in the air. So that's why these filters and universal masking and physical distance and cleaning and disinfection are important for environmental controls. Next slide, please. So the key takeaways here: ventilation, the movement of air in and out of spaces. Ventilation in enclosed spaces is key for infection control. Good ventilation removes things in air that shouldn't be inhaled, like viruses and other germs. Questions about ventilation in healthcare? Definitely talk to facility engineering or maintenance staff. Let's see, next slide, please. Okay. So infection prevention control, environmental domain. Why does good ventilation matter? So good air handling in healthcare settings can help reduce the risk of respiratory infections spreading among patients and staff. An air exchange means the air in a room is replaced with new air. So air changes are usually measured by the hour. In healthcare facilities, nearly every type of room has a recommended number of air exchanges. For example, 12 ACH are recommended for emergency department waiting rooms. Maintenance and facility staff should check rooms used to care for patients with COVID-19 to make sure they're providing the expected number of ACH. The ACH will tell you how long the room should sit empty after the person leaves and before another person can come in without a respirator or other PPE. It is okay to enter a room before the air is completely cleared, including while the patient is still there, if you use the recommended PPE, including a fit-tested respirator. So one way to check if there's ventilation in the room is look for vents and fans. And there are some simple ways to increase the ventilation in a room, like opening a window. But because rooms are often connected in healthcare facilities, doing some of these things can change the air pressure and ventilation in those spaces. So always check with your building's engineer or maintenance staff or the people in charge of your facility before you make any changes. Next slide, please. So some key takeaways. With the takeaways highlighting air exchange, let's apply what's today's COVID-19 ventilation intervention. So if less than 24 hours have passed since the person who is sick or diagnosed with COVID has been in this space, clean and disinfect the space. If more than 24 hours have passed since the person who is sick or diagnosed with COVID-19 has been in this space, cleaning is enough. You may choose to also disinfect depending on certain conditions or everyday practices at your facility. If more than 3 days have passed since the person who is sick or diagnosed with COVID-19 has been in the space, no additional cleaning is needed. And next slide. So knowledge check here. Do you still need to wear face masks if your ventilation is sufficient? So go ahead and make a selection. All right, next slide. All right, so thank you for your responses. So we'll just finish and get closer to this piece by saying that, how ventilation should function. Really, engineering controls to contain or prevent the spread of airborne contaminants center on local exhaust, general ventilation, air cleaning, and general ventilation just encompasses dilution and removal of contaminants via well-mixed air distribution of filtered air, directing contaminants towards exhaust registers or grills via uniform non-mixed airflow patterns, pressurization of individual spaces relative to all other spaces, and then pressurization of buildings relative to the outdoor and indoor attached buildings. Next slide, please. So ways to improve ventilation. Certainly optimize the use of engineering controls to eliminate exposure by shielding healthcare personnel and other patients. Physical barriers and dedicated pathways to guide symptomatic patients through triage areas is one way. Remote triage facilities or patient intake areas is another. If the climate permits, outdoor assessment and triage stations. Vacuum for surgical procedures could be used, and reassess the use of open bay recovery areas. You can also explore some other options that might optimize air handling systems. So those are just some ideas and ways to improve ventilation. And now I will go ahead and turn the presentation over to Karen to discuss the alternative disinfection methods.
Thank you, Rochelle. So with this environmental infection control on additional disinfection methods, we'll be covering the use of dedicated medical equipment that has been used for caring for patients with suspected or confirmed COVID infection. All non-dedicated, non-disposable medical equipment used for patient care should be cleaned and disinfected according to manufacturer's instructions and facility policies. Ensure that environmental cleaning and disinfection procedures are followed consistently as well as correctly. These same routine cleaning and disinfection procedures, such as using cleaners and water to pre-clean surfaces prior to applying an EPA, Environmental Protection Agency registered hospital-grade disinfectant to frequently touch surfaces or objects for appropriate contact times as indicated in the product's label, are appropriate for COVID-2 infections in healthcare settings, including those patient care areas in which aerosol generating procedures are performed. Proper management of laundry, utensils, and medical waste should also be performed in accordance with these same routine procedures and guidelines. Thank you. Next slide. Regarding infection control programs, the multi-layered approach. This approach includes staff safety and competency in clinical practice with the focus on hand hygiene, wearing face masks, and physical distancing. Institutional policies that ensure vaccinations, immunity titers are updated with the new employee orientation, such as MMR, varicella, hepatitis B, as well as annual validation of flu immunization. The hypothesis is that this will likely be true for COVID vaccination as well, although this is still to be determined. Regarding clinical operations, there'll be improvements with building ventilation, and that should be coordinated with engineering and building maintenance. Thank you. Next slide. With the same multi-layered approach, we covered the importance of wearing masks in addition to ventilation. It is suggested that air purifiers alone cannot replicate the reduced concentration of viral particles by natural wind and social distancing, which is possible in the outdoors. By itself, increasing ventilation is not enough to protect people from COVID-19. When used along with other best practices recommended by CDC and others, increasing ventilation can be a part of the plan to protect people indoors. Thank you. Next slide. Regarding operation policies, the integration of administrative controls. So these are the easier implements for sure. The UIO audience here are absolute experts. They're pros at the mastery of the new normal routine from early on in the pandemic, where there's been a limiting of the occupancy by spacing out of appointments. No longer are we at the Q15. We're looking at more 30 minutes plus, as well as just building that virtual capacity for service delivery. Steps to ensure that everyone adheres to source control measures and hand hygiene practices while in a healthcare facility include signs and posters in the entrance areas, waiting areas, elevators, cafeterias. These would all provide instructions to visitors on the proper form of source control and how that is worn, in addition to the performing of hand hygiene. Additional implements would include providing the supplies for respiratory hygiene with masks, as well as cough etiquette with signage again. There should also be the availability of alcohol-based hand sanitizer that is at least 60 to 95% alcohol, tissues, and no-touch receptacles for disposal at healthcare facility entrances, waiting rooms, and patient check-ins. Overall, there should be a limiting and monitoring of points of entry to the facility, whereby processes to ensure everyone that enters is assessed for symptoms of COVID, exposures to others with suspected or confirmed COVID infection are practicing source control. Many of the facilities already, I'm sure, have lessons learned, successes to share in our breakout rooms shortly regarding their individual screening practices, the implementation of electronic monitoring systems in which individuals that are visiting the facility can report their symptoms or lack thereof for fever or other symptoms of COVID, the absence of a diagnosis of COVID infection within the past 10 days. These are but a number of administrative implements in which to do environmental control. Thank you. Next slide. Regarding other operation policies in integrating administrative controls include properly managing anyone who is with active or confirmed COVID infection, doing that contact tracing, for example. Healthcare personnel should be excluded from work and should notify their employee health should they need further evaluation for COVID infection. Visitors as well should be restricted from entering the facility and should be referred for proper evaluation if they are suspected or confirmed to have COVID infection. Patients should be isolated in an examination room with the door closed. The same examination room, if it's actually not available, then patients should not wait among other patients who are seeking care. Instead, if possible, identify a separate well-ventilated space that allows for waiting patients to be separated by at least 6 or more feet, and that there's easy access to these respiratory hygiene source control supplies. Patients should also have the option to wait in a personal vehicle outside the healthcare facility as long as they are stable. Then they should be contacted by phone when it is their turn to actually have their own evaluation. Healthcare facilities should also consider designating a separate area within their facility, such as an ancillary building or a temporary structure or a nearby location in which there can be evaluation of patients with symptoms of COVID or are seeking attention or care for COVID. Next slide, please. And with this knowledge check, I invite everyone to respond to this question that is showing up in the prompt. The layered approach only includes wearing face masks and hygiene. True or false? Go ahead and respond, please. So I'm going to give you a couple more seconds to respond to the question. Okay, the answer to the question is false. The layered approach includes improvements in building ventilation, physical distancing, wearing face masks, hand hygiene, and vaccination. Thank you all for participating. Now I will hand the presentation over to Kaylee. Thank you.
Thank you, Karen. Ha'ahat hatewe bosa kumbak iha Kaylee Edwards. Hi, everyone. Thank you for joining this call. I graduated from the University of Oklahoma with a degree in psychology, and now I'm a first-year MSW student at WashU. I'm studying American Indian Alaska Native, so I'm really grateful to be a part of this program. Next slide, please. So in connecting what we're learning with air ventilation to culture, the first thing that I thought was, honoring air. And so I was taught that, air is kind of the first gift. It's the life force that allows us to even be able to live. And so when thinking through wind in connection with like the spirit world, some significant elements for Native communities are fire, air, water, and earth. And so it's really important that we honor air. And so with the pandemic, air ventilation is a way that we can do that and how we can protect our community members. Next slide, please. And so when thinking through more of a community level, of course, protection of community members is at the forefront. And a sense of community is very important. So if you're trying to be with a relative or other community members, like Karen and Rochelle were saying, doing a layered approach is very important to, stay safe or, trying to be outdoors to lessen the risk of infection. And so good air ventilation protects people at high risk. And so within our community, elders are the knowledge holders. And so it's really important that we follow those protocols so that we protect people who are the most important and most vulnerable within our communities. So with that, I will pass it off to Dr. Carlson. So thank you.
Hi, everyone. So I am just here to link some threads together of many different things that we've talked about today. The focus has really been on ventilation and on administrative controls as the themes. And I think where I pull this together in my head is around the idea that this is not just about personal behaviors, but that there are systems in place as well to help us achieve the things that we wish to achieve in terms of preventing illness and preventing infection. And so, we look at a lot of things in infection control and we say, people should stay 6 feet apart. They should put on a mask. They should clean their hands. They should stay home when sick. And we focus a lot on behaviors, but ventilation and administrative controls are great illustrations of the importance of not depending on behavior, of designing systems, of designing buildings, designing spaces that are going to protect people without us necessarily doing anything specific. So, and this is a theme you'll see more and more coming out, both of Project First Line and I think infection control in general, this thought that really what you want to do is to make it so that it's not dependent on people's behavior in order to protect them from illness. Ventilation is going to be a sort of a big theme even after the pandemic here. In healthcare, I think people are much more aware of ventilation than they ever were before, and of what it means to have a room have good airflow and good outside air coming in. So you'll find, I think, more and more discussion of what do we do to make the best airflow possible, while at the same time balancing all of the other issues involved in healthcare, including but not limited to cost and resources, and also what is actually what you need to achieve a good reduction in risk versus what is less important. For those of you who are going to get down in the nitty-gritty of, okay, I have ventilation in this space, I need to figure out what it is and what's going on, the number one thing is often to recognize that you need a specialist in this. And most of the time, that's the person who works with your heating, cooling, and air conditioning systems, your HVAC person. Some facilities will actually have facilities or maintenance staff, but if you don't, it's the person who would service your heating, cooling, air conditioning, who can help with figuring out what your ventilation is in a space. It's important to work with them because sometimes you will change something and not necessarily realize that there are other recommended parameters that still need to be adhered to and that might be violated if you are continuously opening a window or if you change the way the air flows from one space into another. And the most common examples of that, honestly, are things like medication rooms and clean and dirty utility rooms, which actually have a separate number of air changes and outside air and airflow that they need, as well as temperature and humidity for the sake of sterile supply storage. So it's very complex. Don't expect yourself to know a lot of details. The most important thing to know is when you need to talk to your HVAC folks to get your system to the best it can be. And realizing that in a lot of outpatient settings, as we know, there are lots of challenges with not being the owners of the building and not necessarily having people who are familiar with healthcare involved. And we can talk through some of that in the break rooms as well if there's interest. But I think, again, my main messages are recognize that as you go into advanced topics, you're really talking about how do you build systems to protect people, and the ventilation is a great example. Administrative controls are another. And then knowing when in these processes to bring in experts in other fields to help you optimize your environment for health. And that is all I have for my commentary.
Thank you so much for your insight, Kaylee and Dr. Carlson. So now we'll move into our breakout rooms. We're going to be divided up into 3 rooms to answer the question as seen on the screen. A dialog box should appear on your screens to join the room. And when in the room, just for the breakout leaders, don't forget to hit record. And we'll see everybody back in 15 minutes.
And for those of you who aren't following the news, the CDC did announce that people can go maskless if they are fully vaccinated, but that does not apply to health. So in healthcare environments, if anybody says, can we take our masks off? The answer is still no in all healthcare settings. This is really outside of healthcare where they've made the change.
I have a question, Dr. Abby, actually, because of that.
Sure.
So what about the people that are kind of in that weird limbo? They would just have to wear their mask until they're able to get the vaccine if they had already had COVID?
Yeah, I honestly don't know where they came down. Let me just pull up the guidance here. I had it up the other day. I don't know where they came down on that in terms of the people who were ill. Can they restart within the 3 months of their illness? I think that is still, I think there's still kind of jury's out. So they didn't specifically address that. So I think really for now, it only applies if you truly got vaccinated, not if you were sick and are immune.
All right, just curious. Thank you.
Yeah, no, that's a complicated one that I think they're gonna have to ponder. I suspect very soon you'll have that group will get a clear to go to, but not quite yet.
Awesome. Okay, looks like we have everybody back. So welcome back, everyone. We are going to start off with Evie's room to discuss the breakouts and what the group covered. And then next we'll go to Dion and then Melissa.
Sure thing. In the meeting room, I hosted Bakersville with Johnny in the room. Native Health had their team, Angela, Bettina with safety, and David with facilities department. So the common thing here for this particular group in their conversation was centered around building ownership was not necessarily owned by the UIOs. So the facilities upgrades and to meet certain standards regarding ventilation was and has been a challenge. And so some of the immediate things that some of the teams are doing are looking at a system where they're able to set up in their building a system that may, an HVAC system, I'm sorry, that would meet the needs of their current patient care settings. Moving forward, they also have opportunities to move or purchase buildings where they're able to have more flexibility in the design, the implementation of the proper setup which is required for healthcare delivery. A lot of great talk about how some of this conversation through this particular talk today, the presentation topic, is really allowing the team to move forward to begin planning and all of those things. I also want to note that the team had questions on recommendations around the HVAC systems, how often, for example, the filters need to be changed, what the recommended level should be for certain healthcare settings, and that sort of thing. So I won't take much more of the time. I hope I did justice for the team members, but it is very impressive to see Native Health with their safety and their facilities leads on the call today. Thank you.
Thank you. And now Dion's group.
I believe that's our group, so I'm going to be reporting out. So in our group, we had Rochelle and Nancy. Rochelle is from the Salt Lake area. And so some of the difficulties that they found at their site is that some of the buildings are older and some are newer. So just figuring out like the need for updating the systems in the older areas. And then something that would definitely be helpful is, getting more research to support the fact of needing to spend the extra money because it is very expensive to update with COVID considerations in mind. And then moving to Nancy with Fresno. So she was just really saying that they have limited space inside. And so they've moved a lot of the COVID testing outside, which has been pretty effective so far. And then Rochelle provided a example of another clinic that moved all of their departments outside with the help of the health department in their state. And so that's something like to consider for, Nancy's area. But yeah, I think that was pretty much it. And just thinking through ideas of, calling like maintenance or getting the HVAC checked and those considerations too for the sites. So I'm not sure if anything else I left out, but.
Thank you, Kaylee. And last but not least, Melissa's group.
Hey everyone, I'm going to report out for our group. Erin, Abigail, Karen Harrison, and Dawn were in our group. So some of the obstacles that we talked about was one being the location of the building, where in it. I think Karen and Abigail talked about how they were on the second floor and there's no HVAC system. And they actually have a shared system, and then where the cooling tower is located on the building was a big issue. And then thinking about that moving forward, I think another thing that they brought up was like not being part of those conversations when talking about where the building is or what happens to the building, or like talking about air circulation. I think another issue was that their windows do not open, and so they had to come up with different ways to kind of circulate the air. And I believe that they used a lot of different air purifiers for now in dealing with the COVID-19. And then we talked about another big issue is like, I think for Denver, for Aaron, is that not owning the building and then not having a lot of say in like what happens if something does happen, and then it's a bigger issue for having to wait through and going through maintenance staff and scheduling, and that creates barriers. Another thing we talked about was spacing issues, and throughout the pandemic with the growing staff and renovations and adding space and permits, it also creates barriers and it's challenging. And then I think Karen Kwok also talked about how that also ties into fairness and equity, and then just the lack of ownership. And then another thing that Abigail talked about was that although it could be different constant challenges around architectural dependent places, you could I think a thing that you could think about is like thinking about contingency measures. Although it's like smaller risks could pay off better than the other bigger risks, especially now with a lot of limitations. I hope I didn't miss anything. I think that's good.
Thank you, Haley.
You did great. So thank you everyone for that really great discussion, really good points and challenges. So next we would like to move into the slide presentation. Sorry, one second.
Stephanie,
so
there's
thank you
one
again for
comment
joining.
in the,
Oh.
Yeah, there's
Go
one
ahead.
comment from Johnny. Johnny indicates that he didn't mention in the discussion, but a huge challenge they face is funding. Affording minor improvements, but the amount it would cost to, retrofit a building is something we currently do not have funding for. I think funding is also another aspect as far as challenges and some obstacles for a lot of our urban Indian health organizations across the country. But thank you for highlighting that, Johnny. We'll make sure we notate that as well from NCUI's end.
Yes, thank you.
And just a quick point for not just the administrative perspective that Johnny brought up in terms of contracts with ownership of the building, but in terms of HVAC maintenance at the get-go, could it be when you secure the equipment that there is built-in times for its renovation and the changing of the filters, as was asked in the first group? And then in terms of evidence-based science research, those resources will be made available in the follow-up thank you email. Thank you.
Yeah, so thank you everyone for your time today. And a really big thank you to Rochelle, Karen, Kaylee, and Dr. Carlson for their trainings and commentary. And as a reminder, we have the post-evaluation survey that we ask you to complete. The link has been shared in the chat. And also, if you could take a few minutes to provide us feedback on our training to better create trainings for you in the future. And then we have our CDC Project First Line resources, as well as our presentation resources. And then our next training module topic will be cleaning and disinfection in healthcare. So please save the date on your calendars for May 27th at 2:30 p.m. Eastern Standard Time, and keep an eye out for the invite. And again, just thank you for your time, and please complete the survey. That just helps us with our training for all of you. So thank you again and have a great day.